Hello, everyone, and welcome to a very special Preemie Chats today. Today, we are recognizing World Breastfeeding Week. Thank you for joining us. I'm Leah Whitehead. I'm a preemie mom and a volunteer with the Canadian Premature Babies Foundation. And I'm joined here today with Fabiana Bacchini, the Executive Director of the Canadian Premature Babies Foundation.
Hi, everyone. Hi, Leah. Thank you so much for hosting this session today.
It is my pleasure. The Canadian Premature Babies Foundation is also known as CPBF, and it's a charitable organization. Its mission is to support and educate Canadian families of premature babies. This Preemie Chat series is one of the many ways that CPBF shares information with NICU families and healthcare professionals. Here every Friday, we talk with medical professionals, researchers, and parents who share with us their NICU experience and knowledge. And we want you to be a part of the discussion. So please let us know you're watching by leaving a comment or a question for any of our guests. Be sure to check out CPBF's website. It is canadianpreemies.org. And there you will find all kinds of resources and support. Parents are the most important people and intervention a baby can have in NICU, but NICU itself can be disorienting, to say the least. So on this website, there it is on your screen, you'll find resources like the new video series, Welcome to the NICU, that hopefully will make you feel like you just know a little bit more about NICU and your invaluable role there. The theme of this year's World Breastfeeding Week is Step Up for Breastfeeding, Education and Support. And today's lineup is full of both of those key elements, education and support. This special edition is coming to you in collaboration with EFCNI, which is the European Foundation for the Care of Newborn Infants, GLANCE, the Global Alliance for Newborn Care, EPIC, CNN, the Canadian Neonatal Network, the Canadian Association of Neonatal Nurses, and FICARE. Breastfeeding has global implications for families, but for NICU families, it's a journey that can look very different. And on top of that, the COVID-19 pandemic made something that feels challenging more like nearly impossible. The COVID-19 pandemic has significantly altered how breastfeeding support is provided, resulting in mixed breastfeeding outcomes and experience. Our first guest will review pandemic-related changes in guidelines around breastfeeding support across 5 countries: Australia, New Zealand, Canada, the United Kingdom, and the United States. She'll then unpack how these changes have impacted breastfeeding initiation, duration, and breastfeeding and chest feeding experiences. She'll then move on to recommendations for clinical lactation support as we move forward into a post-pandemic era. And so to lead this presentation, I'm pleased to welcome Dr. Mary Lee Brockway. Dr. Mary Lee is a PhD prepared registered nurse and international board certified lactation consultant with expertise in maternal child health, infant feeding, and patient engagement. She is currently an assistant professor at the University of Calgary and is developing a program of research examining the use of human milk as a clinical intervention to mitigate early life perturbations to the infant microbiome. Welcome, Mary Lee. It's awesome to have you here.
Thank you, Leah, and thank you to the Canadian Premature Babies Foundation for having me. I'm really excited to talk with you today. So as Leah mentioned, I am going to be talking about a study we just completed that looked at breastfeeding guidelines and support disruptions from the COVID-19 pandemic, and talking about how we can move forward with some learning that we took away from this experience. First, I want to just acknowledge that I have no financial conflicts of interest with the information presented here today, and also that I'm not receiving any payment for this presentation. I also want to acknowledge that I'm coming to you from the city of Calgary, which is on the traditional territories of the people of Treaty 7 region in southern Alberta, as well as home to the Métis Nation of Alberta, region number 3. So we've just recently published this study in the International Breastfeeding Journal, and I believe Leah is going to put the link up. It's open access for anyone who wants to look at it. It is quite an extensive study. It has 3 parts, which I'm going to review with you briefly today in about 15 minutes. So we'll see how that goes. So what I want to do from today's presentation is summarize the existing evidence of how the pandemic has changed breastfeeding initiation, duration, and maternal experiences with breastfeeding support. Look at how those supports changed over the pandemic, and then how we can integrate them into future practice. So the way we went about this study is that we looked at the 5 countries of Australia, New Zealand, Canada, the UK, and US at the obstetrical guidelines from those countries and how they apply to women or parents coming into the hospital and delivering who were presumed COVID positive or confirmed COVID positive, and what sort of restrictions were in place. And we compared it against the World Health Organization recommendations for breastfeeding with presumed COVID positive cases. So you can see this chart here at the top. We have the World Health Organization guidelines with 4 major outcomes that really impact breastfeeding. Those are skin to skin, rooming in, direct feeding, and then a new outcome of breast washing that was recommended as a prevention of spreading COVID when infants were directly breastfeeding. And really what we found is that most countries aligned very quickly with the World Health Organization guidelines, and this is from March 2020 till December 2020. So the World Health Organization came out with guidelines, and most countries were very, very quick to align with what the World Health Organization was recommending, except for the US. They really kind of followed their own path, and they really, in the US guidelines, didn't find any support of mention of skin to skin. There was consistent separation of mother and infant throughout that first 9-month period, and direct breastfeeding was rarely encouraged in cases where COVID was suspected. And we found this to be especially concerning because not only for US parents, but in our review, we found that many, many countries refer to the Center for Disease Control and the ACOG guidelines in the US for their own breastfeeding guidelines. So this misalignment with the World Health Organization guidelines and these disruptions to breastfeeding support were actually far expansive beyond the US and could lead to disruptions across the world. And I've highlighted this rooming in piece here because this is a maternal-child separation issue. And I know that that has come up continuously with the Canadian Preterm Babies Foundation and parents of preterm infants, because that child separation from parents is concerning for multiple aspects, and one of them being breastfeeding. So once we established these guidelines and these disruptions to breastfeeding through these guidelines, we then went on and did a literature review looking at breastfeeding experiences from the COVID pandemic. And unsurprisingly, we found that mothers who were diagnosed with COVID or suspected with COVID experienced reductions in breastfeeding initiation and duration. And the biggest factor to those disruptions was the maternal infant separation. And we found that moms that were separated from their infants, most of them experienced reductions in breastfeeding initiation and significant disruptions in breastfeeding duration. And one study we looked at found that none of the mothers who were separated from their infants were able to successfully establish breastfeeding later on. So this really emerged as a profound disruption to breastfeeding, and something that we need to really consider moving forward in our own practice, but as we deal with other new emerging pandemics if they happen. Also, we found that mothers who were non-COVID positive really struggled with breastfeeding if they were lower income. They were impacted most really over the course of the pandemic. Specific to Canadian mothers, we really tried to pull out some of their experiences, and negative experiences related to the pandemic restrictions were, of course, no social support, because we were restricting visitation and discouraging congregating in closed spaces. A lot of mothers reported difficulty receiving professional help with breastfeeding techniques over the phone, as that was how most breastfeeding support was offered, either over the phone or virtually. A lot of mothers expressed fear of developing low milk supply due to the stress of living during the pandemic. Some expressed challenges with lack of care provided in the hospital. This could be related to the short hospital stay. And then lots of mothers also reported having poor mental health due to stress of the pandemic, increased responsibilities and other aspects of their lives. And this often led to some stopping breastfeeding sooner than they were desired. Now, I do want to point out that I do say this is Canadian mothers from studies in Canada, but this was also reflected in studies from the US, the UK, Australia, and New Zealand as well. Positive experiences did also emerge from breastfeeding or from the pandemic as well. And lots of moms said that they were able to be afforded more time to focus on breastfeeding. There were fewer distractions around. They were able to bond with their baby without distractions because fewer visitors were coming through. There were less social expectations on people. Lots of mothers reported that their partners were located in the home for work, so there was greater partner support. And also for them themselves, they were delayed returning to work so that they could actually breastfeed longer and weren't forced with returning to work and trying to balance breastfeeding. However, it's important to highlight that this was mostly reported among mothers that were higher income, who had few pre-existing mental health challenges and who had less complicated births. Now, looking at breastfeeding support specifically, we found that most breastfeeding support groups, both peer and professional based, moved to online or virtual platforms. And while this was a massive transition, lots of moms actually did find it helpful, preferring one-on-one video calls and social media support to being their preferred platforms when looking at virtual aspects. So it wasn't all bad. But the one thing that came out of this is healthcare is very slow to change. So the pandemic forced us to shift very, very quickly. And it was what we call a source of disruptive innovation. So we wanted to look at this as an opportunity to explore these virtual platforms and look at them as a way to modify how we provide support to breastfeeding families. In order to do that, we conducted a SWOT analysis. So what a SWOT analysis is it looks at strengths, weaknesses, opportunities, and threats of a new innovation or practice, and kind of breaks them up to think of a way, opportunities and threats moving forward to using that new innovation in a practice setting. So thinking about online and virtual support for breastfeeding and looking at potential strengths and opportunities of that, we found that there's increased convenience. Families don't have to leave their home. It's increased accessibility to breastfeeding services, especially for those who live in rural or remote communities and don't have those resources available to them in their town. It also reduces commuting time for breastfeeding support professionals or peer workers. So it increases their availability of the care provider. So you can go from one meeting to the next without having to commute. And that may in turn reduce wait times for accessing these care workers or these professionals. Also, virtual care provides an opportunity to triage breastfeeding families so that we can allow them to be seen quicker, either virtually or triage to receive in-person care if they actually are deemed to require that. So in fact, it actually can increase the efficiency of how we provide care. Now, of course, there are weaknesses and threats to this online provision of care as well. The biggest being lack of universal access to reliable internet. Of course, you need internet for that. And internet restrictions are predominant in rural, racialized populations and those who have lower socioeconomic status. And these are also people who already experience healthcare inequities. So there is a risk of perpetuating these existing inequities. So we have to be very aware of that. There's also concerns around privacy standards and patient confidentiality in the online environment, which of course our professional bodies are addressing. And then, of course, one of the big aspects too is sometimes we actually, as breastfeeding professionals, have to get our hands in there and conduct physical assessments, and you can't do that in the online environment. So moving forward, looking at these opportunities and threats, we think it's important for care providers to embrace these disruptive innovations and think about ways that we can use these new methods to improve the care we provide. And I think the best way to do that is integrating virtual care provision options with existing breastfeeding supports. And we can do this to streamline our breastfeeding supports that we have right now to provide more efficient and equitable access to families. But of course, prioritizing those interactions that require physical assessment to be in person. And we can do that through that triaging aspect I spoke to. And of course, really thinking about these new opportunities through an equity lens so that we're not exacerbating existing inequities or access to care. So in conclusion, from this study, we really found separating mothers or parents from their infant is very detrimental. We know that from a breastfeeding perspective. We know that from a preterm infant perspective, and it should be avoided at all costs. This also increased our awareness of social inequalities and the potential for this disruption of the pandemic to increase disparities in healthcare access. So we need to be aware of that and mitigate that whenever possible. Virtual support is not all bad and can help improve efficiency of care. And we do have to be careful when working in online environments that we have to access privacy, access, and acuity of concerns. So with that, I would like to thank the research team, Sarah Turner and Bridget McCann. And I do have the reference there, and I can see in the chat here that Fabiana and Leah don't have that link, so I'll pop it in so that they can put it in the chat as well. I'll take questions at this time.
Thank you so much for sharing that presentation. It's very interesting to see from a global perspective, because I know in my experience, we would have seen changes in our NICU. And one of the things that we found, and I'm just wondering if you can speak to this a little more Canada-wide, is that it seemed like when the pandemic started, no one really knew what we were dealing with. And so we had like this extreme separation of families.
Yes.
And then as information evolved, it became a bit more, I guess, breastfeeding friendly in terms of people then started prioritizing that.
Absolutely, Leah. And what you're talking about there is the precautionary principle. So when we have a risk that we don't fully understand, we try to prevent that risk as much as possible. And it was at the cost of breastfeeding. We saw that also with the AIDS pandemic, that we were really restricting breastfeeding because we didn't understand what the risk was. And you'll find in more risk-averse societies, such as the US, they continued that precautionary principle for longer, whereas less risk-averse societies, maybe such as Canada and Australia, were more willing to support breastfeeding because we know it's really good for infants. Even if there is that risk, it's a risk-benefit analysis, right? And we were feeling that the benefits definitely outweighed that small risk of transmission with the more information that we got.
I just have one more question for you, and then we will move on to our next presentation. But I'm wondering about, you talked about using an equity lens in moving forward. And so can you give us a little bit more as to how individual NICUs could do something like that?
I always go down to patient engagement for that. So asking questions of your patient, it's patient-centered care, really identifying if there's any inequalities, the determinants of health that may be impacting care access. And I really always just go back to asking questions and really making it patient-centered. It's harder when we're working with populations, but when we're sitting down with families, having those conversations and really doing that holistic care aspect and asking them what kind of support they want and they feel they need. Here is what we have to offer, what works best for you.
I so appreciate that perspective. Thank you so much for your presentation, your wisdom, for sharing this knowledge. And I'm sure we'll see more research come out even as we move into that post-pandemic time that we're all hoping is very soon.
Hopefully.
But thank you so much for joining us today.
Thanks, Leah. And I'll pop that link in the chat for you.
Yes, thank you. Please do. Our next guests had a daunting goal: improving breastfeeding rates in their NICU. And so they noticed in their NICU that the rates were decreasing. So they reintroduced colostrum kits as part of every admission. In their presentation, they'll discuss the importance of breast milk, especially for premature infants, and the role of colostrum kits in helping to initiate pumping soon after birth. We'll hear how their unit's doing now and what the future holds for them. So I have Ashley Alonius and Ellen Cobell. They both began working as RNs in HSC Winnipeg in 2014. And they're both now clinical resource nurses there. And they're passionate about neonatology and caring for the smallest patients and their families. And so I would like to welcome Ellen and Ashley. Thank you for joining us.
Thank you.
Thank you.
I will let you get right to your presentation.
Okay, excellent.
So good afternoon or good morning. So I'm Ashley Alonius.
I'm Ellen Cobell. We are NICU nurses and CRNs, or clinical resource nurses, at the Health Sciences Center in Winnipeg, Manitoba.
First, we just want to thank the CPBF and Fabiana and Leah for asking us to speak here today. Breastfeeding and ensuring our babies get the best care is a top priority for us, and therefore that's how this project came about throughout the pandemic.
Okay, so just a little bit of background to start off with. We know that there's clear evidence to suggest that mother's own milk, or MOM, is beneficial for all infants, particularly preterm neonates. Specifically, we know that it is shown to reduce the rates of sepsis, bronchopulmonary dysplasia, necrotizing enterocolitis, and retinopathy of prematurity. We know that it decreases length of hospital stay and improves long-term neurodevelopmental outcomes. However, we do know that there are lots of challenges associated with providing MOM.
So some of these challenges include socio-demographic factors such as maternal age, socioeconomic status, educational level, and family support. Mothers with medical or obstetrical complications such as maternal diabetes, hypertension, or having had a C-section can all affect MOM and their production. Also, education and supports provided both antenatally and postnatally within the postpartum unit or an NICU. Also, the training and comfort level of our staff is definitely a huge one. Early MOM expression and access to a hospital-grade double electric pump is crucial. So in our NICU, multiple factors affected our unit's breastfeeding rates and in turn the initiation of MOM in our unit. In January of 2018, there was the discontinuation of lactation consultants in all of the areas at HSC. This included labor and delivery, NICU, and in our postpartum units. This directly affected the support for our families and our new parents. We moved to a new hospital in December of 2019, which included years and years of planning, as well as the amalgamation of multiple units into one cohesive NICU. Of course, the pandemic challenges. We also rolled out a milk barcoding system, which has proven to come with its advantages as well as its own challenges. And we've experienced an extremely high turnover of staff, which makes staff education very difficult.
So when we looked at our data, we looked at comparing 2017 to 2020, the percentage of infants receiving mom had an overall downward trend. So on day 7 of life in 2017, we were at 75%, and in 2020, it dropped to 63%. So we knew we needed to do something to improve our rates, which is why our focus turned to the reintroduction of the colostrum kits. Colostrum kits were something that we were doing before in the old hospital, but with the move and everything that kind of went along with that, it kind of fell off the radar and was pretty much forgotten. So we felt that this small initiative of reintroducing colostrum kits was the first step towards our bigger goal.
So the official rollout of this project was on November 1st of 2021, and it was part of an EPIC initiative. Our overall goal was to increase the rate of mom feeding to 80%, which we didn't really have anything to compare to data-wise recently, and for 100% of our families who have an infant admitted to the NICU to receive a colostrum kit. This included both premature or term infants.
So to do this, we had to get staff on board through multiple platforms. So that included an education board in all of our pods, posters, lots of emails, staff huddles, and lots of one-on-one conversations.
So the photo here is a picture of what our colostrum kits contained. They were put together by our nursing assistants under our team's guidance. After increasing staff awareness, these kits came to fruition. They included multiple sizes of syringes, medication cups for collection through hand expression, especially for those first few drops of colostrum, which we know are so important, labels, and information for families. They're stored in multiple locations across the NICU, including our infant resuscitation room, within the pods, and in our infant nutrition storage room.
So the parent handout that we included in the colostrum kits was created alongside our team and mother-baby unit. It's a double-sided document, so it has information for both term infants and preterm infants. We worked really hard with mother-baby unit to create the document, as well as mother-baby unit L&D and our transport team to ensure that all of our families are getting a kit. So that's prior to delivery, postpartum, or in the mother-baby unit. The document emphasizes hands-on pumping and the use of a double electric breast pump, which can be found in all of our NICU rooms and on our mother-baby unit. It stresses the importance of pumping soon after delivery to help get milk started, as well as detailed instructions on how our facility labels milk. As you can see, there are QR codes on the handouts linking to videos on how to pump and how to hand express. On the side for premature infants, we also have a link to the Feeding Your Baby page from the Canadian Premature Babies Foundation and a video about hands-on pumping.
So because this began as an EPIC project, which we all know focuses on infants born at less than 29 weeks gestation, it would not allow for a large enough sample size for us to audit. So we chose to include all infants born under 33 weeks in the data you'll hear about now.
So from our rollout on November 1st, 2021 to January 1st, 2022, when we did our first audit, we were at about 40% of parents receiving a kit. Currently, so that's until August 1st, 2022, we are at 56% of kits being given. So it's an improvement, but we still recognize that there's lots of work to be done. So some reason that we heard that kits weren't being provided was a mother's transferred to ICU after delivery, and then infants born outside of the center and transferred in. Documentation of the kits being given is also a big issue. So we send out reminder emails, put up posters, and try to address these gaps in education. So some challenges that we've faced is the overwhelming size and complexity of our new unit, which seems to make everything difficult for our staff. Staff not feeling like they have time or knowledge to help parents pump or breastfeed. It's hard to get new information out to the masses, and there are many changes with policies, workflow, and education in the new unit. So like we said before, the major factor was kits are being given, but not always documented. So this obviously makes it difficult for auditing. We've had conversations with families who have a kit. You know, they bring down the milk and the syringes with the labels that we've provided for them, but it's just not documented.
So some of the lessons we've learned is the main one is it really takes a village. We realize the importance of working together as a cohesive team to really make this project work, or any project that goes out in the NICU. This included physicians, dietitians, our occupational therapists, nursing assistants, and of course, all of our bedside nurses. It is a lot of moving parts that need to align. For example, if our nursing assistants are really busy and there's not enough kits made, we found they just weren't handed out. So the only way to improve is to continually audit and to see where we're at and how we can keep improving. On a plus side, in June, we did have 80% of our admitted patients were receiving breast milk at some point within their stay.
So some of our future plans, we obviously want 100% of our families to be receiving the colostrum kits. So in the near future, that is our main focus. We will also continue to audit the rates of mom and compare that to our previous data from obviously 2017 and 2020, like we talked about, as well as audit our breastfeeding rates. We're hoping to be able to audit or track specific amounts of breast milk provided, especially in that first week of life, because we know that can correlate with long-term breastfeeding success.
Another one of our goals is to have every infant receive mom before 6 hours of age, which will be another facet of this project and something we'll also be auditing. Our unit also just participated in a breastfeeding survey with one of the maternal fetal medicine physicians, as well as one of our own neonatologists. They were collecting information on the views of breastfeeding to then help improve the breastfeeding rates. So this is something that we hope to use data for many projects in the future. Thank you so much for listening.
Thank you so much for sharing that presentation with us.
Thank you.
Sounds like you guys put a lot of work into this.
Yes, a lot of work.
We still have Fabiana with us, but she's having some Wi-Fi issues. So she had a question on how can this be duplicated in other units to improve rates? Have you put any thought into that?
In all honesty, I feel like a lot of units are probably already doing something similar, whether it's actually handing out colostrum kits or being able just to access those families before a delivery of a premature baby happens or an infant that we know is going to get admitted to the NICU. We even know our physicians, when they go and consult, you know, they do talk to those families about, are they planning to breastfeed? Are they planning on pumping? So I feel like a lot of those conversations happen, and, you know, it's just a matter of actually collecting the data. Yeah. Kind of formalizing it into a project. Yeah.
We have a question here as well from Sandy. She asked a question online and she said, we are wondering who does the data collection at your hospital?
Yeah, so that's a great question. We have a nurse who is in a role of just data collection. So I think she works, I think her EFT is about 0.8. And she does data collection for a lot of our kind of ongoing projects, as well as the Canadian neonatal network.
Yeah, we wouldn't have a lot of our data without Shayna.
Yeah,
so.
Thank you, Shayna.
That is awesome. And she had a follow-up question. Is your NICU a level 3?
Yes.
Okay. I think we have time for one more question. So I'm just wondering, conversation-wise, so with these kits, how valuable is the conversation that has to go along with them to talk with families about the importance of colostrum? Yes,
absolutely. So the kit only goes so far, right? So it is absolutely like a team effort. So when our neonatologists are doing the antenatal consults, having them have conversations about the importance of breast milk and pumping, and even, you know, before a delivery, sometimes our resus nurses are able to meet with families and give them the kit at that time and have a conversation about kind of how to get started, but also the importance of breast milk. So that at every interaction, just stressing the importance, and any little bit will help. You know, we can do OIT or mouth care with those first few drops. It doesn't have to be a significant volume to feed with, but I think the repetition of the information is very important.
Yeah, and I feel like we've done really good with, even in, you know, rounds with our team, talking about that out loud, mentioning breastfeeding, talking to the parents, you know, and I think just the bedside nurses really getting on board and kind of having those conversations with the parents at every turn. And we know there's lots of challenges to why someone might not choose not to breastfeed, but then at least we kind of have those conversations prior to kind of just,
I think, giving them the information and letting them make the best informed choice is so important.
Well, thank you so much for joining us today and for sharing this exciting initiative to improve rates. And I hope that you do get to your goal of having 100% distributed, but it sounds like it really is a team effort. And so I just commend your team for working together to make this happen.
Thank you.
Thank you. We've touched on this a bit today, but this next guest is going to deep dive into human milk feedings and the benefits for all babies, especially those who are receiving care in NICU. So Carrie Ann Berga is a perinatal consultant at Champlain Maternal Newborn Regional Program in Ottawa, and she teaches nursing at 2 Canadian universities. In her current role, Carrie Ann supports various initiatives for best practices in neonatal care. She is a NRP instructor and trainer for neonatal resuscitation, a workshop facilitator for human milk feeding, and a breast and chest feeding champion as co-chair of the CMNRP Regional Breastfeeding Committee. Carrie Ann believes in supporting and promoting informed decision-making, family-centered and family-integrated care, and is a strong proponent of the fact that supporting families with human milk feedings can impact the health and well-being of families, both the baby and lactating parent, now and in the future. Wow, thank you so much for joining us today.
Thank you so much for having me. It's such an honor to be here with all of you. So I really appreciate it. I'm going to try to share my screen now, my slides.
Help you with that.
There we go. We've got them up. Okay, thank you. That's wonderful. Yeah, so thank you so much, Leah, for the warm welcome. And I'll get started right away with a question for you. What if I told you that there was a magic solution that could activate the immune system to fight off infection, contains immunoglobulins that bind to the mucosa of the gut, that has anti-malignant properties? What if I told you the solution had iron-binding proteins that help prevent GI illness, that includes things like fatty acids like DHA and ARA that support vision and brain development? It has prebiotics and probiotics that can modulate immune responses to protect the intestinal barrier, that it even adapts to the needs of the human that's consuming it, and has the perfect amount of macronutrients, including carbohydrates, fats, and proteins. It even holds enzymes that produce anti-inflammatory and bactericidal actions. And finally, what if I told you that people both giving the solution and receiving the solution would receive health benefits, including even reducing the risk of certain types of cancer? Well, you may have come to the conclusion that I'm going to be sharing more about the magic and what seems like magic and the actual science of human milk today. So, hi everyone, my name is Carrie Ann Berga. I'm a registered nurse and lactation consultant, and most importantly, a mom to 3 great kids and 2 dogs too, we'll add that in. And I am so happy to be here with you today to share more about human milk. I'm really passionate about promoting and sharing best practices for human milk feeding for all babies. So before we get started on the topic, I just wanted to pause for a moment and acknowledge that Champlain Maternal Newborn Regional Program, where I'm a consultant, is located on the traditional unceded territory of the Algonquin Anishinaabe people. And I would also like to take a moment to acknowledge that the land that I'm currently joining from this morning is Alberta, which is Treaty 6 territory. And you can see I've got pictures of both of those locations on my slide here. And I honor, respect the history, languages, ceremonies, and culture of the First Nation, Inuit, and Métis people who call this territory home. There are so many amazing facts about human milk, and I won't have time to cover everything today, but I can give you a primer on it, or even maybe it will be a review for you. But either way, I always love to come back to the facts about human milk. And even hearing Ellen and Ashley talk about reintroducing a practice, I thought, we do need to come back to things sometimes. So I hope that there's something today that you'll be able to take away about the benefits of human milk, and then we'll talk about some strategies to support families. So, for example, when we look at human milk, fats are put together in milk in a way that makes it easy for the milk to digest. So, for example, fats are packaged with this enzyme called lipase, and when it hits the stomach and it's activated, it helps babies to digest human milk. Human milk also has a unique pattern of fatty acids. I already mentioned DHA and ARA, and those are associated with cognition, growth, and visual function. Human milk has nutrients and specific factors that promote the infant, their gut maturity and immunity. It has growth factors, immunoglobulins, oligosaccharides, and these are special sugars that I'm going to talk about in just a couple minutes. And there are also anti-inflammatory molecules, antibacterial enzymes, and again, this helps fight off bacterial and viral infections. And the really cool thing is that these components are actually higher in preterm milk, since we're talking about babies that are in the NICU today is really our focus. So there's additional benefits of milk. We talked about how easily it can be digested, and in the context of premature babies, very low birth weight infants actually absorb more than 90% of the lactose in human milk, whereas only 68% of lactose is absorbed from bovine-based formula. And the cool thing is that extra 10% that's unabsorbed actually contributes to softer stool consistency, non-pathogenic fecal flora, improved absorption of certain minerals, and more. We know that human milk has a faster gastric emptying time, so it's not sitting in the stomach as long. It stimulates GI growth, and it helps babies to reach full feed sooner. Human milk also reduces the risk of necrotizing enterocolitis, which Ellen and Ashley also chatted about earlier today as well. In terms of the immunological benefits, there's many that I've already mentioned. However, another component of human milk are HMOs, or human milk oligosaccharides, and these are special sugars that have a protective role for the immunocompromised preterm infant and for healthy infants too. HMOs mimic specific bacterial antigen receptors to prevent bacterial attachment to the host mucosa, so the baby's not absorbing that bacteria, which is amazing. Oligosaccharides also inhibit bacterial binding and are a natural anti-inflammatory agent. And this is what you may have heard being referred to as a prebiotic. So these aren't sugars that the babies are absorbing. It's just helping, something that's helping to protect the infant. And I was really excited to hear that Mary Lee is doing work on the human microbiome, because this sort of fits in with that topic as well. And one of the very first articles that I read is here, the review article about HMOs. And there's been so much more work and research done in this area since that article was first released. And I think I might have been at one of Mary Lee's talks when I first learned about this topic. There are also anti-infective properties, and the human body really needs, sorry, I just had a flash on my screen there. The human body makes milk to meet the needs of each unique baby, and it changes and adapts over time. So for example, total protein is higher in preterm colostrum than it is in term colostrum, because it's meeting the unique needs of that baby. Lysozyme destroys bacterial cell walls, and that's higher in preterm milk, and it's not found in formula at all. Lactoferrin binds iron and stops bacterial growth, and is also higher in preterm milk, and again, it's not found in formula. IgA, which is a immunoglobulin, is higher in preterm milk and does not exist in formula. So these immune globulins are very unique. And again, they're almost doubled in preterm milk. And so you can tell that that protection that these babies need is available through human milk. And there's more. There are decreases in length of stay for babies receiving human milk. Necrotizing enterocolitis is decreased. Bronchopulmonary dysplasia is decreased, and other challenges that preterm infants can face are also, the risks are decreased. Human milk also saves the healthcare system money, and additional costs of providing human milk are quite minimal compared to the cost of medical and nursing care of a baby with necrotizing enterocolitis, for example. And the reason that I touch on this is because it can be important for leadership and for policymakers when making decisions about supporting the provision of exclusive human milk diets. So a little bit of work and effort in the forefront can really pay off in the end and really help support these babies and families. In Canada, there was a recent cost analysis completed by Van Katwick et al. In 2020 that demonstrated that providing an exclusively human milk diet to preterm infants who are under 750 grams at birth is likely to save over $100,000 per year. In the US, another study in the previous slide, and I have citations for everything if anyone wants copies of them after, by Johnson et al. Actually said that mother's own milk and donor milk was associated with $15,000 lower cost per infant, and saved about $1,800 per percentage points in neck incidents. So it's compelling. It's compelling for the lactating parent. It's compelling for the baby, and it's compelling that we need to know that we can share this information with policymakers when we're creating plans, such as the colostrum kits that Ashley and Ellen were talking about earlier. Okay, I'll just go to my next slide here. So we have just scratched the surface of some of the benefits of human milk. And there are so many more that we could talk about, but we would have to probably sit here for 12 hours or more. So I just wanted to move on to some evidence-based practices that we can talk about and implement with our families today. So everything that we've talked about today, the great thing is it's all evidence-based. We have years of research and literature and anecdotal evidence from various sources, including the most important people, families, and the babies that we work with, and the opportunity that we have to connect with. So let's talk about zero separation and family integrated care first. The Canadian Premature Babies Foundation has done an immense amount of work in this area, and that's initially how I was connected with this organization. There is extensive research and many personal stories from family and healthcare professionals about the benefits of zero separation and family integrated care. And I've just put a couple samples of some resources and references on the slide, but if you're interested in more information, Canadian Premature Babies Foundation has a lot of great resources, and I'm happy to share things outside of this presentation as well. So a few examples: keeping birthing parents and babies together allows for more skin to skin. Did you know that when moms are exposed to a virus, they produce antibodies that then are transferred to their baby through human milk? So they can fight off whatever virus the mother's exposed to and what the baby's been exposed to. So that passive immunity is amazing. And that can't happen if we're separating moms and babies. We even know that mothers who are immunized against COVID-19 pass along those helpful and protective antibodies to their babies through human milk. So it really is, feels magical, but is also scientific. Even when mothers or lactating parents kiss their babies, there's an immune response. So if you can see like a mom in the NICU or parent NICU kissing their baby, that there's germs maybe on the baby's mouth, and it's transferred to the mom, and the mom will produce antibodies. And again, those things can't happen when moms and babies are apart. There is extensive literature about the importance of family integrated care, and I'm just touching on a very few points and a few articles today, but the answer is really clear. Parents should be with their infants, and we actually need to do a lot of work to intensify parental participation in care. And I know some of the organizations that are joining us today have really been working on that, which is excellent. The next thing I want to talk about is skin-to-skin care. It's a non-invasive evidence-based strategy. It allows for an enhanced sense of bonding, decreased anxiety. It lets parents learn their baby's cues, and of course gives them more self-esteem and mastery in caregiving skills. For the infant, it improves thermoregulation, so keeping baby at the perfect temperature, improves oxygenation. They have less periodic breathing, apnea, and bradycardia. They have longer bouts of regular sleep after skin to skin. And we know that babies who do skin to skin actually move in the NICU from an isolette to an open cot sooner. They're discharged home sooner. And in the context of breastfeeding, skin to skin stimulates prolactin and oxytocin, which means more milk supply and improved breastfeeding and chest feeding rates. So lots of great literature out there about skin to skin and the benefits. And it's so important, that kangaroo care in the NICU setting. Something else that we should be teaching all families before they go home is hand expression. And it was so great to hear Ashley and Ellen share their journey to reintroduce colostrum kits earlier in today's session. Even the smallest amount of human milk are liquid gold. Sometimes hand expression helps people to get out those small amounts that are perfect for a newborn or a preterm infant. if you're looking at, wondering how to do hand expression or how to teach families that you're working with hand expression, there's a couple free videos online. Jane Morton has a great video through Stanford Newborn Nursery, and also BC Healthy Families has another great video on the website as well. So we can keep those small amounts of colostrum for oral immune therapy, as we talked about earlier. And we know that helping lactating people to collect and administer colostrum to their neonates in the NICU can actually engage and motivate them to continue to pump and provide human milk for their hospitalized babies. So it's really such a great way to build confidence, to engage and motivate families. We can also introduce non-nutritive sucking in the NICU, and the Foster reference that I have on here has some great information, and that's just something that we want to think about as we're moving towards those full feeds at the chest or breast. Finally, setting parents up for success with pumping is so important. Early and frequent milk expression with a hospital-grade double electric pump and providing support for transitioning to the direct chest or breastfeeding prior to discharge is key, and the evidence tells us that over and over again. Lactating parents may experience a decrease in milk volumes with those prolonged stays or prolonged separation, and it's really important as healthcare providers that we're checking in to see what their volumes are. Do they have questions? Do they need more support? We also want to make sure that parents have a quiet space to pump and the opportunity to try evidence-based strategies such as hands-on pumping, massage prior to pumping, because we know it's really not difficult. It's not easy. It's very difficult to pump when a person isn't relaxed. So we need to consider ways to promote that relaxed and comfortable family integrated environment for families. And these are really low cost interventions, again, that can create long-term impacts that really will affect milk supply and feeding outcomes for the families that we have the opportunity to work with. So my last slide about this topic and some of the strategies is community follow-up. And Marilee touched on this a little bit earlier as well, which was really helpful. When we think about follow-up and discharge from the NICU, the Baby Friendly Initiative from the Breastfeeding Promotion of Canada and World Health Organization, UNICEF, states that we want to provide a seamless transition between the services provided by the hospital, community health services, and peer support. Preparation for discharge is key in the NICU, and we've heard earlier today the challenges of, not having potentially in-person visits or, maybe a limited number of people that an organization can see for follow-up in a day. So we want to start thinking about discharge right away, and families should have support early on and on an ongoing basis. So whether it's community health centers, La Leche League, private practice LC clinics, hospital clinics, public health, peer support, primary care, those are all organizations that are really important to be aware of so that parents can seek support early and often. You'll want to know the resources, of course, in your community as well. Under step 10 in the BFI, there should also be evidence that each facility is using targeted approaches to reduce inequities. And Marilee touched on this as well. We want to make sure that people have access to care and equal access to care, and that the healthcare provision is equitable. Despite lacking data on human milk feeding outcomes for Black, Indigenous, and people of color in Canada, there is extensive research in the US that demonstrates there are racialized disparities for both preterm birth, which really fits with our discussion today, and for human milk feeding with mother's own milk between white and Black mothers. And that's the Hoban reference that I had on my screen earlier, and I can share that with you if you're interested. And part of the step 10 of the BFI in Canada is working on reducing those inequities. And again, coming back to what Marilee said, it's really about ensuring accessible, individualized care. Many people have preterm babies early and unexpectedly. Parents may have not even had the opportunity to take prenatal classes. And it's really important that we're providing that unique, individualized support based on their needs in their communities. So I love this quote from the Dalai Lama. I'm kind of a quote person. And I just think this is that, could say lactating parents' milk is a symbol of compassion and human affection. And how lucky are we that we get to support families with this journey. So mother's own milk, which Ashley and Ellen talked about earlier today, is a cost-effective strategy. It reduces the risk of comorbidity associated with prematurity and helps to improve the long-term health of infants and families who are in the NICU. Mothers and parents of infants in the NICU may experience health concerns that can really impact their lactation physiology. So we talked today a lot about strategies to assist parents, including parental education, qualified lactation professionals, early and frequent milk expression, those awesome colostrum kits that we learned about, and providing support for transitioning to direct breast or chest feeding prior to discharge, followed by that equitable, timely, accessible, and appropriate follow-up care. So this quote really reiterates the importance and normalcy of needing and accessing support for human milk feeding. It's normal to need support. Breast and chest feeding is an instinctual and natural act, but it's also an art. The reality is that most lactating people can provide human milk and have enough human milk for their babies, and they can learn how to overcome problems, both large and small. It is almost always simply a matter of practical knowledge and not a question of good luck. And so letting parents know it's okay to need support and it's okay to reach out. That's how I sort of wanted to close today. It's really vital that we continue to collaboratively work together to promote, protect, and support human milk feeding. And I hope that you'll learn something. Maybe you've learned something new today, or there's something that you can take into your practice from the discussions that we've had. So, and again, as I mentioned, I do have lots of references. If you're interested in having the reference list, I'm happy to share. And my socials and my email is on here as well. So thank you so much again, Fabiana and Leah and the group for having me here today.
Thank you. What an interesting presentation.
Thank you.
It is amazing, the whole human milk thing and its impact. And I just, as a NICU mom myself, it is an added challenge, and we talked about that a little bit, of breastfeeding in NICU. And often we have an idea of how our journey is going to go, and a lot of that is taken from us just because of our experience. And so I'm wondering, stress, you talked about having a quiet environment, all the things that kind of impact your milk levels, doesn't often happen in NICU.
Right.
And there's a lot of parents who talk about how they have to stop pumping because of their own mental health. And there's a large amount of guilt that goes along with that, especially when we know what's best practices and we all want what's best for our children. And so how do we help those parents with their journey, and how do we support them in what can be very disappointing for them?
And that is such a great point, because everyone's journey is so different. And I think, that is something that when I worked as an IBCLC clinically, is sometimes it was having that conversations with families to say, you are still an amazing parent. You are still an amazing mother. You are, the best person for this baby. And there's still ways that you can, it doesn't mean that you're not going to bond with your baby if, you're not providing human milk or not breastfeeding or chest feeding. You can still do skin to skin. And I think that we put a lot of pressure on families. And I think we have to remove that pressure, because really it comes back to the support that we're giving, and that the system, when I say the we, I say sort of the overall system. We need to provide better support for families. We need to have better prenatal support. We need to have better postnatal support. It's not a parent's fault if their breastfeeding journey didn't go the way that it did. And I have three kids myself who I breastfed all of them, and each journey was so different. So I think it's just, I think it's really important that we don't make parents feel guilty, and that we take the onus, I think, as at a system level and as healthcare providers, that it's our job to support. And it's okay if everyone's journey is different. Yeah, that's a really good question, Leah, because it can be really tough.
And how do you balance that? So you were talking about, support versus pressure.
Mhm.
How does that look different in the NICU environment? Because I think the intention is not, certainly not in our NICU, is to pressure families, and yet
No.
they feel it. So how do
Mhm.
we have that balance of, you need this information, but don't take it as pressure?
Mhm. Yeah, I think that's it's about informed decision making and doing what's best in the moment. And I do think that, above all, mental health is number one, because if we don't have a healthy parent who's feeling good physically and mentally, that can also be, concerning. And we want to promote healthy attachment and healthy bonding and all of those things. And as I said, there's other ways that people can bond and they're still going to attach to their baby. They're still the most important person in this baby's life. So I think that's something that we always need to keep in mind, and we also need to examine our own biases as well as healthcare professionals. There have been situations where I've gone to see a family, and maybe I've said, they just wanted permission to stop breastfeeding,
Mm,
and they wanted to hear from me that it was okay. And again, that's a heavy burden to carry, and we don't want
yeah.
people to feel like that. um, Parents are just amazing, and NICU parents even more so. And so I think, yeah, it's just our job to support informed decision making and help people no matter what. Yeah, does that kind of answer your question, Leah? I think it's a really good one.
Absolutely.
It's a
Yes, thank
balance.
you.
Yeah. Yeah.
Yes. I think it's one that we haven't all achieved yet. And it's,
Mhm.
I don't know, that balance of giving information, but not pressuring.
Yeah.
But I love that, even giving people permission to,
Yeah.
it's your choice. And sometimes you feel like you don't have the choice because you're not able to have the journey you want to have. And so I
Exactly. And
appreciate
making
that you're
peace with that,
highlighting.
making peace with that
Yes,
journey.
yes.
That's really important. Yeah. Yeah.
Now,
Yeah.
many families who are in level 2 NICUs, they share with us that they're often rushed to bottle feed in
Mm,
order to get discharged sooner. And so, how do you
interesting.
think we can address that?
Yeah, that's a really good question. I mean, oftentimes in NICU journeys, babies are having bottles, whether it's expressed human milk or infant formula as well. And I mean, I think yeah, that's a tough one. I think sometimes parents are maybe eager to go home too. I don't know. But I think, again, it comes back to healthcare providers providing that support that's needed. And we know sometimes with feeding, when babies are learning to feed, it's sort of we go 2 steps forward, then we might go 3 steps back. And it's just sort of following the baby's lead as well. The other thing is if parents are discharged from the hospital with a bottle and they want to get the baby, asking their healthcare provider, their doctor, their nurse, or dietitian at the hospital community afterwards, because maybe it is a transition after discharge. I know even in sort of the postpartum units, discharge has been a lot more, I don't want to and so again, it's like that immediate support as soon as you get back into the community. I think lots of opportunities. Skin to skin, we know, works really well to increase milk supply and improve feeding outcomes. And patient supports as well in the NICU. We mentioned that as well. There's some great references in my list that talk about that as well. I think those things help. I think, again, it's each maybe a little bit different, but it is possible to get back onto the bottle or being on the bottle for sure with the appropriate expert support. Yeah. So I call it kind of the all day buffet. Let babies do as much skin to skin and feeding as
Yes.
they want to. And it will really help with outcomes too. Yeah. Does that
Um,
answer your question, Leah?
it does. Thank you. I'm
Okay.
giving you the
Thanks.
hard ones.
Yes, that's
I'm
okay.
also wondering, so I know during pandemic, a lot of support people were not able to be in NICU with parents. And so how or did that impact at all people's breastfeeding success?
Yeah, and I think that was something that Mary Lee touched on earlier too, was that impact of separation, and partners are so important to the human milk feeding journey as well. Even if it's getting the lactating parent, snacks and water, or setting things up in the middle of the night for pumping, those kind of things. And so, yeah, I'm not sure. I don't know if Mary Lee can speak to some of her data that she collected on that topic specifically, but I do think that that partner support we know is vital, anecdotally, from parents sharing their stories, and also from the research. Yeah, the partner support is, and the other thing is, when we're together in the NICU with families, the health teaching is for everyone. We're family centered, right? We're talking to parents, other support people. So sometimes that opportunity might be lost. So maybe there's alternate ways that we can make sure that communication and information is being shared with all family members, extended family members, even if that's applicable. Yeah.
Yeah, and I know for me personally, with my husband there, he was in charge of sterilizing the pumping equipment, and that just enabled me to just cross another thing off my list of like,
Yeah.
okay, that's done, because it's already so much work.
Yeah.
And
I love
so
that
for
tip.
that to
That's
be
so
taken
great.
care of. Yes.
Yeah. Yeah. And sometimes partners think, well, what can I do? I'm not very
Right.
much use here, but those things are really tangible strategies that people can help with, and I remember like people bringing me big glasses of water. I was so thirsty all the time,
Yes.
and things like that. And so those little things make a big impact. I love that example. Yeah, that's a good one. Thank you.
And for those parents who are currently in NICU and who don't see um, the light at the end of the tunnel, I think sometimes when we're pumping, it feels like you're never going to get to that breastfeeding stage.
Mhm.
What pieces of
Mhm.
advice can you leave us with for them today?
Yeah, I think it's just taking things day by day and knowing that, your baby's going to grow, and you're going to become more comfortable and more skilled at this. It is a skill. It's something that you learn.
Absolutely.
And you see, sometimes we would see families like after they've left the NICU and have such successful breast or chest feeding relationships afterwards, or maybe they're pumping and bottle feeding, or maybe they're even doing mixed feeding or formula feeding. And it's like, yes, we got here. Like, we got to the place where I'm at home with my baby, and I'm, maybe going to play groups, whether they're online or in person. I'm at so the just kind of, I would say, just take it day by day and lean on the supports that are available, and know your support. So if you have to, join an online group, or connect with the LC at the organization where you've had your baby, peer support is so important. Even like things like La Leche League, they have so many great groups. And yeah, I think it's just step by step, day by day, and all this hard work does pay off. And yeah, I think that's probably the advice that I would give, and just being there with them in that moment. Yeah.
Well,
Mhm.
thank you so much for joining us.
Thank you.
This is
Thank you so
awesome.
much.
Our final topic is not an easy one. NICU and loss, it often goes hand in hand. And while it is an emotional journey, the birthing parent also undergoes a physical journey as well, and one of which involves milk. Our next guest received a parent legacy request that then facilitated reflection on her part and a working together to improve community lactation supports after perinatal and infant loss. Furthering milk bank awareness created opportunities to donate to and support our tiniest humans. Please join me in welcoming international board certified lactation consultant, Alana Lakoff. Alana has a master's degree in nutritional sciences, and she provides NICU nursing care for families and their babies in the Ottawa region. Alana has a passion for supporting families' feeding goals and has been volunteering towards establishing a local milk bank She is also a proud mother of 3 girls. I have 3 girls myself. It's awesome. And welcome, Alana. Thanks for joining us today.
Hello. Thank you so much for this opportunity. I am grateful to be here today. So I'm truly humbled to discuss the topic of human milk donation after a perinatal or infant loss. I'm no expert. I'm a continuous learner and listener. Every family I meet teaches me. So before I go further, I wanted to acknowledge the land in the Ottawa area. So we acknowledge that the nation's capital area is the traditional unceded territory of the Algonquin and Anishinaabe people. And for thousands of years, they've walked gently on this land. May we now walk with them in a renewed relationship based on honor, respect, and peace. I'm actually currently not in that province of Ontario. I'm in Nova Scotia. So I want to acknowledge all of our Indigenous families and people who reside across Canada, and specifically in Nova Scotia, it's the Mi'kmaq people that I am on their ancestral and unceded territory today. So I also wanted to just briefly highlight that I'm going to use inclusive language that represents the diversity in our communities. Parenthood success, thankfully, is not measured by our feeding method. So I will use the term parent to mean all parents, carers, and legal guardians of a baby, and the term mother to mean all women and people who have given birth and initiated or established lactation. I may use interchangeably the terms breastfeeding, chest feeding, feeding human milk, and nursing. Also, exclusive pumping is another feeding route. NICU parents are aware of this, as well as parents with a hospitalized child, and for some children, a medical diagnosis requires a long-term tube feeding and not oral feeding, making breastfeeding or chest feeding not a realistic goal. Exclusive pumping is also simply a feeding choice, a feeding method of choice. I'm open to all feedback and most sincerely wish to uphold respect for all individuals. In honor of bereaved parents, the term exclusive pumping also represents a parent choosing to pump for comfort as part of a weaning plan after loss, and or a milk gift donation after perinatal and infant loss. This slide is to highlight the importance of listening to a parent's voice. Grieving mothers often experience intense physical consequences after losing a baby. The milk produced by the mother after losing an infant has been referred to as white tears. Milk biologically and physiologically comes in after birth from a pregnancy of 16 to 18 weeks and on, regardless of loss. How can we as healthcare professionals listen openly to families' voices to help shape ongoing supports and policies guiding palliative care and a lactation plan? What about World Breastfeeding Week? How does this all fit in? World Breastfeeding Week, which is currently this week, is supported by the Breastfeeding Committee of Canada and is also recognized again in Canada during the month of October. Personally, the more education and awareness about human milk feeding, count me in. Having a recognized World Breastfeeding Week is all about support for babies and their families, but it's also a week to share evidence-based information, support those that are planning or currently breastfeeding, and increase overall community knowledge transfer to further support families meeting their feeding goals. As a lactation consultant, I listen to and meet families with an open heart. I feel many mothers may have the question, why isn't there a week for people who couldn't breastfeed? Breastfeeding Week is not just for parents who have met their breastfeeding or human milk feeding goals. It's also for every parent who ever wanted to breastfeed for a day, a week, a month, a year, and couldn't do so. This includes bereaved parents. I want to shed light and bring awareness about this week, that this week can be incredibly painful for those who weren't able to meet initial breastfeeding goals, and even more heart-wrenching for a family experiencing a perinatal loss. As a healthcare provider, my hope is to not minimize how awful and triggering a World Breastfeeding Week can be to bereaved families. I'm here to say that your feelings matter. You matter. We as healthcare providers, we as a community, we as a bereaved parent, we as a friend and relative want to listen. Many Canadian families experience perinatal loss each year. This includes infertility during the preconception period, and fetal death during pregnancy. I can also add in here that this presentation also reflects infant death, which is a death that occurs in the first year of life, which is further broken down into neonatal or post-neonatal death. The type of loss does not predict a family's experience of the loss. Parents of multiples face a unique situation between grief at the loss of the baby and joy at the survival of the other baby or babies. Some parents worry that their fear or grief may affect the surviving baby or babies. The support and care that parents receive around the time of perinatal or infant loss is crucial, as it may affect their long-term well-being. To provide holistic care that is sensitive to individual needs, it is important to take a family-centered integrated approach. I just wanted to take a moment here to reflect on all of the babies and families that we have known who have experienced a loss. Thank you. So what about milk gift? What about donation after loss? The research on milk donation and the process of donating milk after a perinatal or infant loss shows that there is created transformative meaning of the loss with legacy donation. So how can we create more milk donation after loss awareness? So to donate milk, we do need a human milk bank. Use of donor milk is considered a basic right for preterm infants in the absence of mother's own milk. This has already been touched on earlier today. In Canada, we currently have 4 milk banks in Toronto, Montreal, Vancouver, and Calgary. The mothers are screened. It's quite a rigorous process regulated by Habana. To have pasteurized human donor milk, physician consent is obtained by parents. And most of the milk is donated by term moms, and compared to formula, pasteurized human donor milk protects from NEC, and research has observed impacts on retinopathy of prematurity, sepsis, feeding tolerance, and achievement of full enteral feedings. And there's a lot of ongoing research if you look at pasteurized human donor milk. So this is a brief physiology of lactation, which I'm not currently going to go into more detail. This slide, along with the following slide, are from the British Association of Perinatal Medicine, and they had just created this framework in May of 2022, just is brand new. And the framework is written for healthcare professionals about the management of lactation following the death of a baby. Knowledge of the physiology of lactation is important to support women to initiate and establish breastfeeding or pumping, but it's also advantageous in supporting bereaved mothers. The stage of lactogenesis may be different depending on whether a baby is lost to stillbirth, dies shortly following delivery, or after a mother has already established breastfeeding. This framework and flowchart are written for professionals working with parents and families to provide information and guidance in supporting mothers around lactation and loss, where a baby or child is not expected to survive or has passed away. While the focus of the document is around perinatal and neonatal death, the framework was written to be mindful that mothers may be breastfeeding when they lose an older infant or child. In addition, this framework recognizes that support is also necessary for partners and families around lactation after loss. Here's a quote from a mother who didn't have a lactation plan after loss. Personally, I've encountered in the community mothers who didn't know lactation after loss was a donation after loss was possible, and also didn't have a lactation plan, and they suffered alone without supports to manage their milk coming in. The whole reason I started learning a lot about this was a couple months ago, almost a year ago, we did have a community member with a known baby that she was going to lose, and she reached out to try to find out what community supports we had in our Ottawa region and how to attain a pump. And this mama was the inspiration for a lot more learning and a lot more community conversations. So I'm just going to read the words from this mother, Anne Cushman, who wrote a book that I've looked at. We came home from the hospital without Sierra. I was stunned at how viscerally, physically I missed her. They forgot to remind me in the hospital that my milk would come in. My breasts were swollen with milk. I was stunned when I looked in the mirror and saw them, immense and blindly eager. I lay on the couch with ice packs piled on my chest, thirsty and cold and heartbroken. Here's a quote from a mother who chose a milk gift legacy. This quote is also from the British framework that I've recently mentioned. Milk donation isn't the right choice or circumstance for everyone. A lactation plan is part of bereavement care that is sometimes missed. For families, awareness of donation after loss can be empowering, and discussing a lactation plan is part of holistic informed care, regardless of donating milk to a milk bank. So this parent's voice says, I donated milk after my son passed away at 41 weeks. He was stillborn. No one mentioned that I could donate my milk, something that my body was going to start producing, because even though he had passed away, he was still going to be born, and my body thought he needed to be fed. Whilst I was waiting for the induction medication to work, which takes 48 hours, I started to research baby loss, about what my body was going to go through, and I stumbled across the fact that I could donate my milk, Bodhi's milk. Straight away, I knew it was something I wanted to do in his name. I wanted something that I made for him to go to other babies, to help other families. Some of my family members and even the consultants had concerns for my mental health when I told them I wanted to donate. But actually, it was the best thing for my mental health. It gave me a reason to look after myself in a dark, really dark time when otherwise I'm not sure that I would have done. And in my not expert experience, but in supporting families in a volunteer way in our community, choosing to donate, a couple of doulas and lactation consultants have stepped up, and we have bereavement training from the CMNRP, or we've done a perinatal loss workshop. We have helped a couple families wanting to donate after loss, and this quote resonates with some of the families that I've worked with, and that they felt that the pumping and the donation for like a few weeks after their birth helped them. It gave them a purpose, and it gave them something to do and something to focus in on. So it's not the right choice for every family. However, my questioning was, how can we increase awareness about donation after loss? So these are the questions I countered in my own professional practice reflection. As a NICU nurse, we don't follow patients. I'm not following patients that I've cared for in hospital. This is a completely separate volunteer relationship that some LCs and doulas are working on to see how we can increase supports. Midwives have they follow patients for 6 weeks, so they do have a lot of close connection, and I have to shout out to the midwives. For those families, they've done a lot in supporting a lactation plan. So my questions are, how are we currently supporting lactation after loss in our region? How can we offer all bereaved families the opportunity of the option for a milk legacy donation? The death of a baby and subsequent grief is complex. The emotional pain new mothers experience may be compounded by physical pain related to continued lactation when there is no longer a need to provide comfort and nutrition for their baby. Guidance on advising mothers regarding cessation of lactation following bereavement is not always readily available in our delivery rooms, neonatal units, hospital, or hospice setting. It is, and I'm going to share the amazing resources we do have and we are using. So it's just variable. Sometimes information isn't always shared that could be shared with families. These potential gaps in care for bereaved families surrounding lactation is discussed in the framework that has been shared from the British Perinatal Medicine Group. The family that was looking to donate in our region, who had needed access to a pump, started a lot of these conversations with nurses, healthcare providers. I must include Jillian Zolos as a key person supporting my learning about donation after loss. And there are many others within our region who listened to my questions about current community lactation support after perinatal and infant loss, from social workers to some NICU managers. I've talked to a bunch of different people, and so grateful for the ongoing conversations, exploring informed practice, knowledge translation, gap analysis, and how to have the conversation about creating a lactation plan after loss. So this is a great place to start. I have to highlight the incredible resources already, like the Canadian Premature Babies Foundation. I will not try to go off too much off topic, but the Canadian Premature Babies Foundation is truly an expert in minimizing family separation. They are strong advocates of zero separation. The pandemic has impacted families from not only having supports during ultrasounds, which is very significant, especially for families. Like sometimes information is provided at these ultrasounds and they didn't have a support person there during the pandemic. And also, I personally have known people that weren't able to have a birth, any birth support person during a birth. Bereaved families were unable to have celebration of lives or funerals or memorials at times during the pandemic based on numbers restrictions. The Canadian Premature Baby Foundation has supported families so much during this time and continues to do so. And I cannot speak more highly of my real life hero, Fabiana, and her brilliant team. So this amazing evidence-based resource is currently what we have in our hospitals. I suggest everyone to go to it. There is a link for families, for professionals, and for volunteers. And then basically on the left here, I didn't put the whole thing here. I can share the links. I have out all of my sources here at the bottom and they're in my notes, but I'm happy to share these links. But if you Google PALE, the Perinatal and Infant Loss Network, the one on the left, it's a handout that we give to families who have experienced loss. And it does mention milk donation as an option. And it's very general. It can be used like across any province. And it's beautiful. And then the lactation after loss, the one here on the other side, they have a whole, like it's all organized. So as a healthcare professional, if I wasn't a lactation consultant, but even as a lactation consultant, like I have learned like just reading through this. So it's very helpful information for any healthcare professional. So these resources we have right now. And I just wanted to say, like, so just increasing my own awareness, like we've recently shared all of the PALE resources at the last 3 NICU education days for nurses, as well as a staff meeting, we have a lot of new staff, just to try to increase awareness. Currently in our community, more collaborative conversations are happening related to lactation support after loss. We've identified the donation criteria for bereaved families. You need to have and this is in conjunction with the Rogers Hickson Human Milk Bank, part of Sinai Health in Toronto. So you need to have at least a 5-liter minimum donation. And this is just for packaging and transport. Like it's all frozen. And so that much volume needs to be there to keep it frozen to make it to the milk bank. A loss after 18 weeks gestation is criteria to donate milk. There's specific collection guidelines to follow, and also a successful screening questionnaire and blood work sample, which you can just get at the Life Labs. They send the requisition. So we reached out to public health, and we have a collaboration with an easy process that we hope to share soon to healthcare providers, where it's just like we can fill in an email drop-down menu on their website to ask for a hospital double electric grade pump that they can bring to a bereaved family within 24 to 48 hours. Because not everyone, if you want to pump, the evidence is to have a double pump. And using a hand pump would work potentially, but just would be a lot longer process. So there is a loaner pump option in our region for bereaved families. If they would like to be connected, ask your nurse or social worker. We can connect you to Ottawa Public Health. Thank you for that, and get a loaner pump to you. And there's also nursing follow-up visits with that. And we plan to share this soon by email to healthcare providers as well as community bereaved supports. These community supports in our area will be shared within the next few slides. So we're also trying to like increase awareness of the community supports we have for families. So through conversations, we've also found several doulas and LCs with bereavement training willing to volunteer to help support a donation plan and safe weaning plan, as well as incorporating sleep rest. Information about suppressing milk production and expressing for comfort, or including how soon to start and how often to express for legacy donation support, can be provided by these volunteers by text, phone, or email. The pumping plan for donation after loss doesn't need to be as rigorous as pumping for every 3 hours for 15 minutes initially. Working to find a rhythm as a volunteer, helping some families in our area and listening to them has been some of the most meaningful learning I have ever encountered. So I've been working in our NICU. We are implementing a loaner pump program. Many NICUs have loaner pumps. Increasing NICU loaner pump programs is a way to help access a hospital grade pump over the weekend or immediately. And this is a short-term plan for like 3 to 4 days until a loaner pump or funding can be initiated, like through social work and like collaborative effort to get a pump. It's just kind of for a short term to help get access to a double electric pump for families that meet the criteria. And that criteria we've like gone through with a family representative. So we've had parent voice implemented into this, and also a bereaved family would meet this criteria if they needed access or wanted access to a double electric pump for comfort or for donation. And then I also wanted to just say I'm not going into the evidence of the double electric pump, but you can check out Dr. Rebecca Hoban's work from Sick Kids. Also, if you're not able to have a double electric pump, a hand pump can also work for relief, but it isn't practical, as mentioned, for a 5-liter donation because it takes so much more time. And I've heard from some bereaved mamas that they do prefer a hand pump when they're pumping for comfort instead of a loaner pump because it's something that they can keep with them and it's not something they have to return. So here's some questions I'm becoming more comfortable in asking and engaging and learning from bereaved families. So the first few questions are like, do you have a lactation plan? Are you aware of the opportunity to give a memory milk gift to a human milk bank? And then the later questions are more like about the process and how they felt about giving a milk donation. So partners matter too. I also want to highlight the bereaved dads. They can have an impact from milk donation, and there's ongoing research in the value of legacy milk donation for the whole family. One of the families that I worked with, her toddler asked if her milk could go for another baby, and this is how she decided to donate to the milk bank in Toronto. So there could be research too on siblings, but I just wanted to highlight that partners are really valuable and matter so much, and their grief is also something that matters too. So here's some of the many supports for bereaved families in our area. This will be added in hospital policies, hopefully soon, updated in websites and shared. We're hoping to do an updated newsletter to healthcare professional and perinatal leaders in our area. There's many, many more too. So I would be open to learning of more. And for healthcare professionals in any healthcare, if any healthcare professional wants to share information and knowledge so I can learn more, please contact me. My email's on the next slide. If you'd like me to share any literature and references from today, I'm happy to email you. My slides are all in the notes. And the next one. So here's my contact information on the bottom in a summary of my presentation. Listening to parents' voices matter. Family involvement, feedback, and sharing their lived experiences after perinatal and infant loss impacts current and future care. Legacy donation awareness creates opportunities to nutritionally support our tiniest humans with pasteurized human donor milk from our 4 Canadian human milk banks. High-quality bereavement care includes compassionate and open communication with informed choice and individualized care. Parents and families need the necessary information and time to make the decisions that are right for them, their baby, and their family. Care and support should always be tailored to meet individual needs, preferences, and cultural practices. A future area I'm curious about is related to learning more about research options that could accept smaller donation volumes for milk gift legacy donations. Check out the UK Chester Milk Bank. They currently accept any volume for a legacy donation, and their program is also called the Memory Milk Gift. How can we support bereaved families returning to work? A bereaved colleague recently asked to do a shadow shift with me in the NICU after 12 weeks off, and this was accommodated by our workplace. How are we supporting each other and our colleagues? How are we supporting families with a rainbow baby pregnancy? I included this butterfly image because it was from a parent's experience that they asked for this butterfly image to be included on the cots to signify the twin status for the surviving baby. And these butterflies originated in 2015, and they've been used in over 300 hospitals worldwide. So there are so many valuable team members supporting bereaved families, from birth centers, NICU teams, hospices, social workers, physician, midwives, pharmacy, nursing, RTs, and more. Thank you to healthcare teams for your commitment to evidence-based ongoing education. Thank you for your advocacy and knowledge. To bereaved families, lean in. There are so many community supports ready and wanting to be present with you in your grief journey. Canadian Premature Baby Foundation is a key place to start with many supports for families. Please see their website. I write their website on every patient now that on the whiteboard. We also do have their information up around the units. If interested in legacy donation, reach out to the milk bank in your area. There is more information coming to healthcare providers in our nation's capital about this meaningful initiative to increase awareness about memory milk gift opportunities to the milk bank in Toronto. Thank you so much.
Thank you for sharing that presentation. I feel like I literally have to rewatch the whole thing because it's so much to take in. And it hasn't really been an area that I personally have thought a whole lot about. And so I really appreciated all that you had to say, and your acknowledgement of World Breastfeeding Week and what that means for all kinds of NICU families was beautiful. And so thank you for even that part of your presentation.
Thank you.
I'm just wondering, it feels like now, and correct me if I misinterpreted this, but that now it's on the family at this point to reach out to donate, or are NICUs, is your NICU starting this conversation?
So we're trying to increase education for healthcare professionals to start and have these conversations, and we're adding it to like our bereavement kit. Things are still in process. Nothing's completely done. But we've been talking about it at our last NICU education days, and then there has been some updates like to some regional education healthcare professional groups, and that's kind of ongoing. So we've started the conversation. We're asking questions. The reason I came onto this was from a community, like a mama asking questions about how do I get a pump? I want to donate. And she hadn't given birth yet. But she was the instigation for me really knowing that I have a huge gap personally, and I need to learn more about this, and just increasing awareness that for families to know that this is an option, and then for every healthcare provider who's in the perinatal world to know that it's not maybe the right thing for everyone, but a lactation plan would be appropriate to discuss with everyone. And then if they want to, then there is that option too, and that we can get loaner double electric pumps for anyone, our public health. Hopefully more public health have loaner pumps, because there is like pumps in the NICU and stuff, but that guidance on how to, when your milk comes in, to have support that you're not too uncomfortable, and that at least you know that this is coming. Sometimes with so much of the grief that's occurring, we're forgetting just to talk about the metabolic, physiological, normal process. If you've already been pumping, that's also something to talk about, but like for a stillbirth or a baby that may not be with us for a significant amount of a long time. We wish everyone was with us longer. Then we can have that conversation, because it will happen to that mom. And like that one quote, it's hard when it wasn't discussed, or they didn't know they could donate, but they feel that would have been important or meaningful for their grief journey.
Mhm. And for you, this is a volunteer thing that you're doing.
Mhm.
And
No,
so
yeah, so to support a mom, because I can't, like, as our nursing body, we can't follow patients from the NICU. I wish we could, but we can't. So this is just like a separate situation that has occurred through a community, like part of a community health center, community health center.
do you
Yeah,
think that's the future though of that following, that consistency? Like, is that what we should be considering and looking at?
I feel like we should ask those families. I think we could look to the midwives. I think they do so much like consistent care for longer than when a family and baby, like after a discharge from hospital or leaving a hospital, we don't have further contact. Like for a healthy prem, we do. We have our neonatal follow-up clinics and stuff like that. But for these families, I think each center is kind of looking to do their own thing. The hospice, like the Roger Nielsen House, has incredible bereavement groups for parents. I've heard amazing things from parents who've attended those, and like they've created relationships with other bereaved parents that like have sustained them. So it's just like I just feel like I've learned so much just from trying to find a pump for someone who needed a pump.
It's amazing that that started this whole journey for you and is really, you know, starting that conversation that is so important to be having.
Yeah,
Yeah.
thank you.
Thank you so much for being with us today. It really was just an incredible initiative to be talking about and to be considering. And I think it's really thoughtful and something that all of our NICUs need to be thinking about. So thank you so much.
Thank you for all you guys do. Have a great rest of today.
Thank you. This has been incredible. Everyone's presentation has just been amazing. And so thank you for watching and for joining us today. All of you who joined the conversation and who will carry on the conversation in your own NICUs. The video of today's session and all the videos from our live series are available and will be available on the CPBF website, canadianpreemies.org. And we want to thank our sponsors of today's session, Medela and AstraZeneca. CPBF is a charitable organization, and it believes that through education and support, families will be empowered and ready to care for their baby. So visit the website, canadianpreemies.org, and consider making a donation. Together, we can create a brighter future for all families. We hope that you will also join us next Friday. It's going to be 1 p.m. Eastern Time again, and we're going to be talking about human milk for human babies, how breastfeeding shapes infant development. We hope you will join us then. Thank you for being here today. And thank you to all of our guests. It was so interesting, and we certainly have a lot to consider.
Started this morning with our service. Looking ahead, some things coming up. We've got bonfire tonight for our middle school, high school students at Luke and Joanna's house. Encourage all of you guys that are that age to just go and join over there. Marshmallows and s'mores and a time of fellowship. So head on over there. If you need directions, check with Luke and he'll get you directions over to his house. Also, next Sunday we'll be honoring Maria and her family and their last Sunday with us before moving. So just want to make you aware of that. Just give them the appreciation that they deserve. Also, we've got Fifth Sunday Rally coming up next Sunday afternoon. All of our community or area churches from kind of the Brookings and area all the way over to Highmore, Diamond Willow, all going to be gathering here next Sunday afternoon. So encourage you to come and fellowship with us. There's a sign-up sheet out on the table with the coffee if you're able to help bring some things, or check with Jackie and she'll get more information to you about that. But come and join with the fellowship and hear more from the other churches as well. We're headed to camp again today with our 7th and 8th graders, so just be in prayer for us this week as we go, and an encouraging time for them. Had a good week this last week. So just keep those things in your prayers. Also, just any other prayer requests that you might have, just get those to us here at the office, and we can add them to our prayer list and just keep those before the Lord. So let's pray this morning together. Heavenly Father, we're just grateful for your many blessings. We're grateful for the opportunities that you put in front of us, Father. Father, we just come before you this morning and humble ourselves, and would you prepare us for what you have in store for us this morning? Open our ears and open our hearts and our minds to your word and to the worship and to just the fellowship this morning, Lord. Be with us as we head to camp, and Father, we pray for the 5th Sunday rally, and Lord, we just commit these things to you, that they would be pleasing and honoring to you. In Jesus' name I pray. Amen.
Morning, everyone. Please stand as we begin worship.
Stop the Lord Almighty. Who can stop the Lord?